Welcome to the PCOS Society of India. As a founder president of the organization, I welcome you all to be part of our organization, which is a multidisciplinary organization consisting of specialists and experts from various fields of medicine who look after women with PCOS and even young girls and even children. Our organization is focused on education of the doctors and education of our patients. With the recent Vyjayanthi program, which we have created through the support of Philips India, we are reaching out to women all over the country. And I request all of you to be part of this program, to take this complete agenda nationally and to educate our women on how they can prevent complications for themselves in future. I also request you to become our members, because that is what is going to help you in updating your skills in this field, which is really a very growing area of treating women and preventing problems in future. Thank you very much, all of you who have been with us, and I look forward to interacting with you in many, many more programs to come.
So, good evening, everyone. This is Priyanka here. On behalf of PCOS Society India and Team Vyjayanthi, I welcome you all for today's panel discussion webinar with experts. Now, these panel discussions are conducted under the CSR project Vyjayanthi the Winner by PCOS Society of India, and it is being supported by Philips. We have been conducting these webinars consistently since last 2 years, where we invite medical experts to discuss and give us insights into various concerns related to PCOS. Now, under Vyjayanthi project, we are conducting sessions in various institutes across India with the help of a specialist to raise awareness about PCOS and identify suspect PCOS cases. So today I'm excited to present you experts who are going to discuss all your concerns related to PCOS and infertility through frequently asked questions and real life case scenarios. So for today's session, we have Dr. S. Vyjayanthi ma'am, who will be moderating today's panel discussion. Ma'am is a director and fertility specialist from Mother to Be Fertility and head of department and consultant in reproductive medicine and surgery, KIMS Fertility Center, Krishna Institute of Medical Sciences, Hyderabad. She has completed a clinical fellowship in reproductive medicine, Leeds Reproductive Medicine Unit, UK. She has completed MSc Embryology from Leeds University, Subspeciality Fellowship in Reproductive Medicine and Surgery, UK, Subspeciality and Accreditation in Reproductive Medicine and Surgery from UK. She's also completed a training in obstetrics and gynecology from RCOG, UK. She has numerous publications to her credit, and she has presented several papers at the national and international conferences. She also runs fellowship programs in reproductive medicine to train the future generation of fertility specialists. So, ma'am, a very warm welcome to you and all the panelists. I request you to take over and welcome other panelists, ma'am. Over to you, ma'am.
Thank you. Good evening, everyone, and a warm welcome. It is indeed a great pleasure to be here today with you all. I would like to thank at the outset the PCOS Society of India for having given me this opportunity to be a part of this awareness session. I would like to welcome my panelists now, Dr. Smitha Nalla and Dr. Sharadha Golconda. Dr. Kameshwari, the other panelist who was supposed to be with us today, is unfortunately not able to join us due to a family emergency. So we will have two panelists today, and I'll be moderating the session. Next slide, please. So we have with us today Dr. Sharadha, who has done her fellowship in reproductive medicine, and she's a consultant gynecologist and fertility specialist at KIMS Fertility Center, KIMS Hyderabad. She has 15 years of expertise in obstetrics and gynecology, reproductive medicine, and minimal access surgery. Welcome, Dr. Sharadha. Next slide, please. We have with us today Dr. Smitha Nalla. She's a consultant endocrinologist at KIMS Hospitals, Hyderabad. She has done her MRCP in diabetes and endocrinology and has completed her CCT in UK. She has worked in UK for 10 years and in prestigious institutions like Addenbrooke's Hospital, Cambridge. She has publications in several index journals and has presented at national and international meetings. We have a long association, Smitha and us. We have been working together for the care of our PCOS patients, I think for close to a decade now. Welcome, Dr. Smitha. It's nice to have you on the panel. Thank you. So next, I'll be starting my session now. PCOS is a subject very close to my heart since my fellowship days of training back in the UK. PCOS is a very common hormone disorder and it affects 1 in every 5 Indian women. And the other thing is PCOS can affect women at any age, right from adolescence right through the reproductive age to menopause. And these women have quite a varied presentation in that some of them present with irregular menstrual cycles, whereas some young girls can also present with issues like unwanted facial hair, acne, and they're quite distressed with that. And some others present with infertility issues. But for the purpose of the discussion today, we'll be focusing only on fertility issues in PCOS. So now to start off with, the way we have structured it is initially we'll be answering some frequently asked questions, and then we'll move on to the common scenarios which we see in our daily practice when we manage patients with PCOS. And the last part would be the questions which we are happy to take from the audience. I'm told already we have some questions, but we feel free to ask any more. Any of you have any more questions, you can feel free to ask. So to start off with, Dr. Sharadha, can you guide us as to what is PCOS and what is the diagnostic criteria we use to define PCOS?
PCOS is a condition which has got its clinical and endocrine manifestations with irregular, most of the women between reproductive age groups being affected with. The 3 criteria we have, out of which if 2 are present also, we consider them to be PCOS. One is any ultrasound suggestive of PCO ovaries, like if the follicular count is more than 20 on the scan, and if the woman is having irregular periods. And the third criteria is any androgenic effects like alopecia, acne, and acanthosis nigricans and all that. So any 2 out of the 3 findings also are present in any woman, we consider them to be having PCOS.
Yes, yeah. Thank you, Dr. Sharadha. So next now, moving on to, we said irregular cycles is one of the criteria suggestive of anovulation. So here we will want to know why women with PCOS find it challenging to get pregnant. And they also have concerns, will they ever get pregnant? So is it a treatable condition? So if you could throw some light on that. Thank you.
PCOS is very much treatable. There's nothing like very scary about it as long as it is managed properly and addressed at an early stage. Every woman with PCOS can get pregnant. It's not that they cannot get pregnant. Only few of them may require some assistance to get pregnant. So coming to the other question you asked, ma'am, in the same.
What is the reason? Why are they having challenges getting pregnant?
That is, it is indirectly the anovulation which is there in PCOS because of the hormonal disturbance and the hormonal irregularities. Because of anovulation, there is difficulty in conception, fertilization, and sometimes and the hormonal changes which are there, they mostly have hyperestrogenic state. Because of that, even if the fertilization is happening, sometimes implantation may be challenging for them compared to women with non-PCOS.
Okay, so the main aspect which reason behind which PCOS women find it difficult to get pregnant is anovulation, right? So that's the commonest reason. Yeah, and it is treatable. We have got stepwise management, how we manage these women when they present with fertility issues. So we'll deal one at a time now. So basically now that we have seen that anovulation is the main reason and it is treatable with a stepwise approach. The other thing which I would like to ask you, Dr. Sharadha, before I move on to a question to Dr. Smitha, can women with PCOS also conceive naturally? Some of them, do they not have issues, or everyone needs treatment when they have PCOS for fertility?
It is a tailor-made approach, madam. Not all of them will require treatment. At the same time, not all of them can get pregnant naturally. It depends upon many other factors associated, like hormonal imbalance, their recent, if the cycles are regular or not, and other parameters as such.
Okay, so when a woman presents with irregular cycles, what are the tests you would do to diagnose PCOS and then to move on from there?
Apart from the regular test, we would also like to run an ultrasound to make sure to see about the ovarian pathologies and the endometrial pathologies in the woman. And then the specific tests which we would want to do is the glucose tolerance test, and testosterone levels, apart from thyroid and prolactin, if they're having irregular periods.
Yeah, yes, that's right. So most important thing is the hormonal evaluation. As Dr. Sharadha mentioned, it is important that prolactin levels and thyroid function tests are done, because some of these women who present with irregular cycles do have issues with high prolactin levels, and any thyroid disturbances have to be corrected before we initiate treatment for fertility, because thyroid hormones are very important for the fetal neurological growth of the fetus. So we have to correct these disturbances before moving on. And another important aspect is GTT. We do know that PCOS women also have metabolic issues. And one of the most commonest is impaired glucose. Hyperinsulinemia is a very common issue with PCOS women. And these women have abnormalities in glucose metabolism. From our own clinical practice, we know that 1 in 3 women who present to us with fertility issues who have PCOS have GTT abnormalities. They have this 1 hour, 2 hour values quite high following a glucose load. And 1 in 10 women are frankly diabetic. So it is very important that GTT testing is done. And if there are any abnormalities, they have to be corrected prior to initiating fertility treatment. And as fertility specialists, we are in a very unique position in that we are able to optimize the health of the woman before we start the fertility treatment. And that we cannot say for our, say, other obstetric colleagues, where these women are already pregnant when they reach out to them. So we are in a unique position, and we take advantage of this, optimize the health of the woman, and then move on. So that is how it works. Okay. So now moving on. Insulin resistance is a key issue in women with PCOS. How do we address this, Dr. Smitha?
Yes, ma'am. So basically, if we come as Dr. Sharadha has nicely elaborated about PCOS, so we're coming to understand why all these women have PCOS, then we get to see that how much role insulin resistance has with PCOS. So most of these girls who present with PCOS, or women who present with PCOS, also have issues with abdominal obesity, or what we call as central obesity. And because of this, they can have problems with either both with the production of insulin and also the way the insulin works in them. And that is what we call as insulin resistance. And there are there's a lot of data to say how insulin resistance actually propagates the PCOS and causes what we call as the hyperandrogenism, or high testosterone levels in these women with PCOS. And also, like Dr. Vyjayanthi has mentioned, it puts them at very high risk of metabolic problems and impaired GTT and pre-diabetes and diabetes even. So addressing this issue of insulin resistance in these patients will definitely help in trying to manage their other symptoms of PCOS.
Okay, thank you. Thank you, Dr. Smitha. So next, moving on, many women with PCOS are overweight or obese. So what is the percentage we would say in, say, Indian population, we see overweight women, Dr. Sharadha, in our practice when they present with fertility issues?
More than 70% of the PCO women are with a higher BMI. And it is very less percentage, around 20 to 25 or maximum 30%, who are lean PCO, who come to us in the reproductive age group.
Yes. So it is quite a challenge to manage these women when they present, because most of them are overweight or obese. So this leads us to the next scenario, which we very commonly see in our practice. So we have a, say, 30-year-old woman who presents with 2-year history of subfertility, and she has irregular cycles occurring once in 3 months, and her BMI is 32. So she is on the obese side. How would you approach with regards to her treatment?
First, if she's not yet, the lifestyle modifications would always be the first target, ma'am. And the lifestyle modifications, we would want them to have a balanced diet, a calorie deficit balanced diet, rather than a low carb diet or high protein diet or any crash diets as such, because PCO is something which needs a long-term modification. It's not just for a short term, or it has to be sustainable also. And giving them targets like 10%, 5 to 10% of their present weight. Suppose they're 80 kgs, lose around 8 kgs in the next 4 to 6 months, which comes to around 1 to 2 kgs per month, which will not be a very difficult task for them. and healthy diet and exercise. Exercise, if it is a moderate intensity one, somewhere around 200 to 300 minutes per week. So if one day they are busy also, the other day they can compensate the activity. If there's somebody who is used to do high intensity, they can do around 150 minutes per week also is sufficient during the initial phase when they are trying to lose weight. Once they get into their target weight and their cycles, few people get the cycles regular and all that also. After that, maintenance is also important. Even in the maintenance part, we would still continue to have the calorie deficit diet, or not very much into calorie deficit, around 1200 calories per day, and around 150 minutes of workout per week to continuously continue the progress which has happened into their body.
Okay. Yeah, so the most important aspect is, as a first-line management, when obese or overweight women present for fertility treatment, is to get their, to reduce, to bring down the weight so that we can initiate the OI treatment or the specific treatment towards ovulation induction, as these women have anovulation as the primary reason for their infertility. Well said. But the most important aspect is we have to give them a goal. You can't just say go and reduce weight. As Dr. Sharadha rightly said, we usually say reduce 5 kilos or 7 kilos. We give a timeline also. And the second important aspect is, if at all possible, ideally, say in our own unit, we have a dietitian who sits with them and plans the diet chart with them. Because what we are looking at here is not a short-term issue. It is a long-term. These women have to be compliant with their diet long-term. This is a lifelong thing, what we have. They have to completely change their lifestyle. So it is important that we achieve compliance, and this is possible when the dietitian steps in and gives a diet which they can follow. So that is very important. And when it comes to the exercise should be, it is an integral part, and it has to happen along with diet, because unless exercise is, unless one does exercise, the basal metabolic rate comes down. Just with diet, they would not be able to lose weight. So they go hand in hand, both diet and exercise. So these three things are to be remembered. Okay. So now once they reduce the weight, how would you say you have given them a timeline, they come back after 6 months and you have seen that they have achieved the goal you have given them, 7 kgs they have reduced. So how would you next approach these women?
We would like to go ahead with ovulation induction, madam, with first line oral ovulogens, which may be letrose and clomiphene citrate. But the first line letrose have shown more beneficial effects than clomiphene in the recent past times. And as you said, if letrose around 6 cycles, if they're ovulating, is good enough for, but in the 6 cycles also, most of them get pregnant in the first 3 cycles, like 70 to 80% gets pregnant in the first 3 cycles. So depending upon their age, marital life, 3 to 6 cycles is a good period for them to try ovulation induction. And if they do not, then move forward for other kinds of treatments like IUI or IVF, if anovulation is the only thing there for them, like PCO with anovulation.
Okay, so we'll do a general workup as you initially mentioned, and if they have got only anovulation as the reason, we are going to offer them OI. Up to 6 cycles can be offered, and if it's not successful, we'll go ahead with the next step in the management. Great, thank you. So now we'll move on to the next scenario. This is to Dr. Smitha. So we have a 34-year-old lady, recently married, BMI is 40, she's grossly obese, and she's anxious to conceive. So in these women who are grossly obese, diet and exercise alone may not help. So when would you consider starting oral, anti-obesity agents for these women? And when would you consider surgery, Dr. Smitha?
Okay, so the main thing to decide in these women is at what point of time they want fertility. Is it in the near future, or they are willing to wait to get to their target weight, or at least a target that we give to go ahead for the planning for the fertility. So in the meantime, as we said, there is no replacement for diet, the low calorie deficit diet, and also the physical activity. But there are drugs which can be tried. The most important drug which we use very commonly and which is available very much and is proven very much in PCOS is metformin. So it's very widely available, and it is used actually for the treatment of diabetes, but it also works very by sensitizing the body to insulin. So at various levels, both at the liver, with the muscle, and also in the pancreas, the metformin tablets do help, and it is very used almost, I would say. I don't know if you would call it first line or second line, but it is part of the treatment for PCOS as well. So we put them on the maximum tolerated dose of metformin tablet. And the second thing which can be considered for these patients, especially in the newer drugs which are available now, are something called GLP-1 receptor agonists. Many of you may have heard of this drug called semaglutide, which works basically by reducing your appetite and also is an insulin sensitizer. It reduces the main part of PCOS, which is insulin resistance, but it also helps to reduce the appetite. So there is very good results we are seeing with weight loss with these with this drug. So we are offering it to patients who have a little bit more time to consider for fertility. Now, coming to the second thing you asked me about surgery to consider in these. Once again, that depends on how quickly these patients desire fertility. So if we are thinking about if the patient is morbidly obese, and if we see other comorbidities, let's say hypertension, diabetes, I think it is to achieve the target weight, and if the patient is willing to wait, say 1 year, 2 years down the line, there are other cardiovascular risks as well. There can be some discussion about bariatric surgery also in these patients. But once again, given the fact that if they are planning for fertility, many of them may choose not to go with surgical option. They may choose with the medical options only.
Okay. How long would you give, Dr. Smitha, medication if you choose to give for these women, and what is the timeline you are looking at?
So with metformin, I think the weight loss side of things start usually by about 1 month, especially if they can get to the maximum tolerated dose of metformin. The weight loss starts by 1 to 2 months of taking metformin, and even the periods start regularizing on metformin by then. So we are saying that maybe if they take it for about 3 to 6 months, by that time they get to their target weight. Similarly, for GLP-1 receptor agonist or the semaglutide tablet that we have, to see any kind of effect on the weight from the semaglutide tablet, usually we recommend that the patient takes the maximum tolerated dose for at least 3 to 6 months.
Okay, so 3 to 6 months is a good time to give a trial to see, if they reduce the weight, and then we are able to move on. So because we don't usually try to start these anti-obesity agents, we usually refer to you. Our sort of management stops short with diet and exercise, and at the most metformin. Of course, these days we use metformin. We can also use metformin primarily in women diagnosed with PCOS. So in this context, I would like to ask Sharadha as to what are the indications for using metformin for women with PCOS?
Abnormal GTT is the first indication. Apart from that, even if the GTT is normal, if the woman is not responding well for the oral ovulogens, it is worthwhile considering to start metformin for them.
Okay, so basically, we now have some research with regards to the metformin, that when you are going to start metformin in women with PCOS, primarily they are approaching you first time and you are going to start them on metformin. Some of these women, as Dr. Smitha pointed out, might help them lose weight, and some of them achieve ovulations. Their cycles can become regular, and they can achieve conceptions on their own. So that is one thing. The second aspect, as you rightly pointed out, GTT abnormalities and diabetic patients, we can use metformin. And the other thing is when they're resistant to ovulogen. So this is important. Now coming back to Dr. Smitha. So when we are going to use metformin, when we have initiated metformin during their fertility treatment period, once they get pregnant, how do you deal with these women? Do you continue metformin or do you switch them over to insulin?
So that is where the tough questions start because there is no definite data for this, whether so the worldwide the practice is different. Some centers do actually stop metformin, but some centers do continue. So the data is, the jury is still out there, and the data is divided whether or not metformin can be used in early pregnancy because of the fear of there is some fear of whether there can be IUGR in some women, and that is the main fear with using metformin in early pregnancy. Certainly, there is no data for any teratogenic effect with metformin. And long term, many of our women with type 2 diabetes have been using metformin through pregnancy, including early pregnancy, without any major problems. But I think my take on this would be that if metformin has been initiated purely for the purpose of PCOS with a normal GTT, maybe you can consider stopping it and doing a GTT again at 10 to 12 weeks of gestation to see if these women develop early gestational diabetes. One other point I would like to add is that, again, going with literature across the research across the world, the data is divided whether or not using metformin in early pregnancy actually prevents gestational diabetes later in the pregnancy. So some studies say yes, some studies say no. So probably the safe thing would be you can consider if it is used only for the purpose of ovulation, it can be stopped as soon as the patient is pregnant, and then do a GTT again at 10 to 12 weeks and decide whether you want to put the patient back on metformin. The second thing is it would also depend on the BMI of the patient. If your patient is overweight or obese, they do benefit more from metformin rather than starting insulin for gestational diabetes also in these patients. And the other alternative would be to continue the metformin through the pregnancy, and but still do stop it for a short duration, do the glucose tolerance test, and decide at that point whether or not your patient needs to go back on metformin.
Okay, but in India we have women from rural areas. Some of them. How do you see the complaints with regards to insulin when you want to manage with insulin? In these instances, would you think that metformin is better for these women?
No, absolutely. Compliance was definitely better with oral agents as opposed to insulin. Even titration of insulin can be an issue where people can't monitor their blood sugar levels. So something is better than nothing. But like if it is a lean PCOS patient who had a normal GTT, and in that case, and their sugar levels are quite high again during their gestational diabetes, then those patients would, people who need insulin, you cannot replace it. I think they do need insulin. But in your typical overweight, 80% of the overweight people who do fall pregnant with that impaired GTT or gestational diabetes, metformin does a wonderful job. It's even better than insulin in these women.
Thank you, Dr. Smitha. That was very clear. Now moving on, Dr. Sharadha. So we have this scenario we see very commonly in our clinical practice. This is a young woman, 27-year-old, married for the past 1 year, presenting with recent onset of irregular cycles and difficulty conceiving. So she mentions during the consult that she has had a weight gain of about 4 to 5 kilos over the past 1 year. So how would you approach this patient?
So with the history, she gives that her irregular periods are just started, like within few months or years. It is the weight gain which is responsible for the irregular periods because of the abnormal hormones and all. So if you can just target her to reduce the weight which she has gained, most of them resume back to their regular periods and they can try naturally during those time. And within 6 months or 1 year, if they don't achieve pregnancy with regular periods also, we can target them for ovulation induction or further treatments. But before that, we would want to evaluate the couple, make sure there's no other factors responsible, and then suggest them accordingly.
Okay, thank you. And another thing is with lean PCOS, when we have, as we were mentioning, 70 to 80% of PCOS women in India are overweight or obese. So the rest 20 or 30% who are lean PCOS, do you have any challenges with regards to OI or ovulation induction when you do for these women?
Lean PCOS, most common issues which we get are if they respond, they over-respond to the ovulogens and gonadotropins specifically. So, and if you're starting them with a low dose, sometimes they may not respond. So it is a little challenging, but not difficult as such. we'll have to give little time and start with a lower dose, and then see how they respond, and only then increase the doses.
Okay. Okay, so that's fine. And the next question is, you have a 32-year-old, the next scenario, BMI of 30, she's overweight, and you have tried first line weight loss, she has complied beautifully, and now you have tried to start her on letrozole, which is the ovulation induction oral medication, which we very commonly use for PCOS women, and you're monitoring the follicular growth. You have given it for more than one cycle, but you see that there is no response at all. So she's quite resistant. So what would be your approach here?
We can try the modern, this like stair-step protocol, where we don't wait for a withdrawal period and then increase the dose. We try to increase the dose in the same sitting, which helps the patient in not wasting much of time, or an extended protocol also with the same dose for few more days. And then eventually, if they're not responding, then move to second line like gonadotrophins or anything as such.
So particularly in our setting where we are a tertiary referral center, we hardly have treatment-naive patients walking into our clinic for OI treatment. So most of these women who reach out to us have already had several cycles of OI in several units before reaching out to us. Some of these women have never ovulated. They're quite resistant. In these women, we have found that these newer protocols work brilliantly. So with these, what do? We do 5 days of letrozole for 5 days. And if there is no response during monitoring, when we do the ultrasound to check if they have responded, we can extend the same dose. Say if you have used 5 milligram, we extend the same dose for 5 more days, and we see brilliant responses in these women. We have been using this in our setting for the past few years with brilliant results. And when we move on to gonadotropins, what would be the approach you take when you use gonadotropins in an OI setting, Sharadha?
We start with a optimal dose around between 75 to 150 rather than a very high dose for these women, madam. And constant monitoring for every 3 days or 4 days and seeing their response. And once we find that the threshold has come, the follicle has started growing, which is more than 10 millimeters or so, we stick to the same dose rather than increasing the dose. And the next cycle, we wish she conceives in this cycle only, but if things don't happen and we'll have to start in the next cycle, we'll start with the dose, which is the threshold in the previous cycle.
We have to be very careful with gonadotropins in these PCOS women because their ovaries are very, very sensitive to gonadotropin injections. So we have to start off with a low dose. And when we do the increment also, we have to be very careful with our increments. Otherwise, we run the risk of the 2 risks which are commonly seen. One is multiple pregnancy, and the second one is what we call as an OHSS. So we have to be very careful in our monitoring. Okay. So what is the role of ovarian drilling? I mean, this is very, very commonly, suggested to women with PCOS, and they come for second opinion many a time. I've been suggested laparoscopy and ovarian drilling. Is it the right thing to do? We get many, patients walking in for second opinion. So what is your take on it?
Some women are also suggested ovarian drilling. They say that they're in a myth that it will also help them in losing weight because PCO is corrected. But it is not so at all. For obese women, ovarian drilling is not at all a modality to go forward with. And in this era of fertility generation and all, ovarian drilling is only for women with lean PCO with high LH levels who have not been responded to first line or second line agents.
Yeah, so well said. Yes. So laparoscopic ovarian diathermy is not for all. It's only for a specific subset of women it helps. And for obese women, it simply doesn't work. But we also have to be very careful towards the side effects of lap ovarian drilling, which is development of adhesions or scarring around the ovary, which itself, and also the second implication of drilling is the number of eggs in the ovary starts declining. And we see many, many women with poor egg numbers these days. And this situation can be quite challenging to deal with. So laparoscopic ovarian drilling has got a very limited role in the management of PCOS. And these days, as Dr. Sharadha said, medical management is very very effective. And so this is something to be remembered, and definitely not for obese patients. It doesn't help. Okay, thank you. So now we now go on to the second line management. We have offered the first line management, which is weight loss. It has worked. And second line, you have offered OI for this couple, and you have tried 6 cycles, but there is no response. So how are you going to move forward?
6 cycles of OI, no response. We would try to give them IUI, and IUI around 3 cycles, 2 to 3 cycles with proper endometrium and the follicles and all. If still not working, then we may have to project them for IVF.
Okay. So when we talk about IUI, what is the success rate you're looking at one cycle of IUI? Because some of these women quite get distraught even when the first cycle doesn't work. So counseling is very, very important. Yeah. So what is the success rate you're looking at from one cycle of IUI in general?
Around 15 to 20% per cycle.
Yes, that's right. So as you mentioned before, majority of the pregnancies happen in the first 3 to 4 cycles. So for 3 to 4 cycles is a good number to look at for IUI before we move on to the next step. Can you briefly explain just in one sentence what is IUI?
IUI is like putting the washed or prepared semen into the endometrial cavity so that the distance the sperms have to travel for meeting the egg is cut short.
And this happens along with the ovulation.
Along with the ovulation induction when the follicles are at the right size after giving the trigger.
So that's great. So if you have tried IUI 3 to 4 cycles, there is no response. So what would be the next step?
IVF.
IVF, yeah. So what are the indications you would say for IVF in a woman with PCOS?
A woman with PCOS, per se, if you put apart like failed ovulation induction, failed IUI, even if a woman with PCO having some male factor contributing to the infertility or some tubal factors which are contributing to infertility, they benefit quite well with IVF.
Okay, great. So is it quite challenging to do IVF in these women with PCOS?
It's quite challenging because, as I previously also mentioned, their ovaries are pretty sensitive and they can suddenly respond for a very nominal increase of dose as well. So the dose titrations have to be very careful in PCOS women and always stick to a little lower dose rather than being very high these things. And freeze-all cycles would benefit them more to prevent ovarian hyperstimulation and give you better success rates.
Okay. So in these women, to avoid complications, these days more we are looking at freeze-all, right? So freezing embryos, yeah? So that you can just elaborate on that a little bit.
Freezing embryos is like when you get more than 10 to 15 follicles in that particular cycle. When you do the pickup and all, we try to we try to make embryos in that particular cycle and freeze them. Give them combined pills or progesterone only pills, depending upon their other medical issues and all. Try to get their hormones back to normal. And once after 15 days or after 17 to 18 days, we look at the ovaries if they've shrunk back to normal or not. And once they've shrunk back to normal, we try to prepare their endometrium with either medications like estrogen preparations or however. Once the endometrium is in the right size and right blood flow to it more than the measurements and all, we try to give them progesterones and then do the frozen embryo transfer.
So to avoid complications like OHSs, these days, when we do IVF in PCOS women, we do this freeze-all technique where we prepare the embryos, freeze them, and at a later date, when they do not have the risk of OHSs, we replace it. This is called a frozen embryo transfer cycle. It works very well with brilliant results in each cycle of IVF. And we have now looked at all the different stepwise management when we have a woman with PCOS who presents with fertility issues. So now, just to reassure the worried is that when you have PCOS and you have fertility issues, please be reassured that with medical help, we are able to help a vast majority of these women achieve a pregnancy with a stepwise approach. The first is using just oral medication to help with ovulation. If that doesn't help, the next step and the final step of IVF. And with this, a vast majority are able to get pregnant. And that is the message I want to give out to you all today. Okay, we have now come to the end of this session. I'll just briefly summarize and then we are ready to take the questions. So to summarize briefly what we have discussed, infertility is very common amongst PCOS women, but with medical help, a vast majority achieve their family size. As a significant proportion of women with PCOS are overweight or obese, the first line management in obese women with PCOS is lifestyle changes, and a weight loss of even 5 to 10% seem to help immensely. And very few need anti-obesity medications or very, very rarely surgery. The medication letrozole is the commonly used drug to initiate egg growth, and a significant percentage of women get pregnant with just oral medication. What I usually counsel in my own practice is that, say 10 women with PCOS come to me with fertility issues, 5 or 6 can just get pregnant just with the oral medication. Another 2 can just get pregnant with IUI, and the last 1 or 2 might need IVF, and that's how we counsel them, and a vast majority can get pregnant. So some women need second line treatment such as IUI, and sometimes IVF. All these treatments have good success rates with minimum side effects. So initial evaluation and correction of glucose abnormalities goes a long way in helping these women achieve healthy pregnancies. A stepwise personalized approach is the key, and a multidisciplinary team where a gynecologist or a fertility specialist, endocrinologist, a dietitian, fitness expert, and a psychologist can work together goes a long way in achieving the desired results. And that is where there's a place for what's called PCOS clinic, where all these multidisciplinary experts come together to work towards the common goal of helping these PCOS women. So that is where we should be moving to move forward. So thank you. So I think now, Priyanka, we have the time for next 15 minutes, I think, to take any questions which have come up. Do you want to read the questions, or you have sent it to me and I read it out?
Yes, ma'am. Please read it out. I've sent it on WhatsApp group.
Okay, yes, I can read that out. So is it the 7 and 8? It says here. Before that, I don't know where it is. But
before that, there is a question related to what are the hormonal changes leading to PCOS, if any.
Okay, so that I think we did address. So,
Yes.
So the hormonal changes. So Sharadha, do you want to take that? What is the hormonal changes we are looking at? It's mainly the slightly excess male hormone, right? So if you can just elaborate on that, just for a couple of minutes.
The estrogen levels are more, the androgen levels are more with this PCOS woman. And
so it's mainly these women, as opposed to women without PCOS, have slightly excess of male hormones called androgens. And these can give the symptoms, as some of the women can present with unwanted facial hair or acne, or as we are mentioning, acanthosis, etc. So that is the main change we are looking at. And this is the sort of thing. The testosterone is high, and if it is very high, then we have to rule out additional issues like some of them have got what is called late onset congenital adrenal hyperplasia. So all this will be ruling out if the testosterone levels are very high. So this is the main issues what we see with PCOS. Okay, so the next question is, for excessive hair complaints, suggest the drug to reduce the testosterone levels. And Dr. Smitha, do you want to take that question?
Yeah, I can do that. And I just want to add to the answer of the previous question also with regards to the hormonal causes. So basically the main thing which is driving, as I said, is the insulin resistance. Some clinicians check insulin levels as well, although it's not recommended worldwide to check insulin levels for these people. But the main things to be checked along with the androgens and estrogen is also your gonadotropins. We do check the LH and FSH levels also in these people. But other, as Dr. Vyjayanthi has already mentioned, we need to rule out other causes of high testosterone. So we do also check something called DHEAs to look for adrenal androgens, and 17-OHP to look for the congenital adrenal hyperplasia. So coming to my question of which drugs can be used for hirsutism or unwanted hair. So the best results are usually seen with combination of what we call as anti-androgen drugs, or which can come as a combined pill of something like Diane or Ginet 35, which is cyproterone acetate is the anti-androgen which is used in that along with estrogen. These are 21-day pills, as you all know. This, if used in combination with a drug like spironolactone, can help to reduce the androgen levels, and that very effective, especially when these two in combination with laser treatment for the unwanted hair works brilliantly for these women with PCOS.
Okay, great. Thank you. So to bring down the androgen levels and then maintenance, right? So both are addressed there. Okay. So now the next question is, how often should we get DHEAS and 17-alpha hydroxyprogesterone level? I don't understand the question, but the main thing is when the total testosterone levels come high, then we move on to do the complete androgen profile, which is what now Dr. Smitha mentioned, which is DHEAS, androstenedione, and 17-alpha hydroxyprogesterone. The reason we do 17-alpha hydroxyprogesterone, as again we have just mentioned, is to rule out late onset congenital adrenal hyperplasia. So in our own unit, when we find that the testosterone levels are higher, we work in conjunction with endocrinologist, with Dr. Smitha, so that we do the full androgen profile. And 17-alpha hydroxyprogesterone measured in the follicular phase, if it is high, then we do what is called ACTH stimulation test to clinch the diagnosis of late onset congenital adrenal hyperplasia. So that is how I would address that question. I hope that answers that question. So how to manage women with PCOS with frequent cycles and heavy periods? So the answer to this would be is based on whether they want fertility or not. So if someone has frequent cycles and heavy periods, and if they are unmarried or if they are not interested in fertility at the moment, then the combined pill would be a good a good drug to, good medication to look at. The other alternative would be progesterones for at least 12 days. Whenever we use progesterones in PCOS women, it should be given for at least 12 days, because without 7 days of progesterone is not going to suppress the hyperestrogenism and the thickened lining these women have. So at least 12 days should be used in every cycle. And another thing is, these women, some of them have longer periods. They are amenorrheic. So in these women also, at least one should aim for a period once in 3 months. The reason behind that is PCOS women develop endometrial cancer at a very, very young age. We have a woman who is only 30 years old who has fertility issues but has early endometrial CA, and this is not rare at all. So when you have a woman who has irregular heavy periods in PCOS, you should always consider doing a pipelle biopsy, what we call a small biopsy of the lining, to ensure that they don't have precancerous changes or even early cancer. So the most important take-home message is regular cycles at least once in 3 months in these women is important to keep the hyperestrogenism, the endometrial thickening under control, so that they'd have regular cycles and it's not heavy. So that's important. So now moving on to the next question. If at all they need fertility, then we'll be addressing them with fertility medication, which we have already discussed. But if they are not keen on fertility, then either combined pill or progesterone at least 12 days every month would be an alternative option. Okay. Now, step-by-step guide for management of PCOS in young girls who are married. I think that is itself is quite a long, discussion point. It will come. So I'm just going to skip that for the time being, for want of time. So now, how to manage irregular periods in a woman who have completed the family but develop PCOS and have irregular periods and hirsutism. So Sharadha, would you want to take that question?
Yes, ma'am. I think
irregular period. I'll just repeat it. Irregular periods who have completed the family.
Hirsutism.
Yes, and irregular
family. Yeah. So I think Dian 35, as Smitha ma'am said, would be a good option for them, with cosmetic procedures like laser hair removal for the hair part. Apart from that, I don't find like it's an easy thing to go ahead with. This is the easy option for them.
Okay, right. So, but okay, fine. So the other thing is, for excessive, the next question is, for excessive hair complaints, suggest the drug to reduce testosterone levels. I think Dr. Smitha has addressed that earlier. I think it's the same question getting repeated. And free androgen index, how frequently should we do? Dr. Smitha, would you want to answer that?
Yeah, I think guidelines don't specifically say that we have to go with free testosterone. If we are, because then it involves a lot of calculation, and I don't think many labs give us very accurate reports of free testosterone. So it depends on the lab that you're getting it done in. Testosterone is good enough. it's very rare that testosterone, the bound testosterone doesn't give us an accurate report. If we are expecting a lot of problems with something we call as sex hormone binding globulin, that would be the only case when the total testosterone doesn't give us the report. If your clinical picture and the biochemical picture don't match, then you need to think about doing a free testosterone. Otherwise, you're okay with doing a total testosterone.
Yeah, okay, great. Thank you. So basically, as we have said, the hormones which we would be doing in these patients would be total testosterone, prolactin and thyroid test we would be doing, and if FSH, LH and estradiol as mentioned. But LH, if it is elevated, as these days we don't look at the FSH, LH ratios, all that has been given up. So we do that as a baseline testing, FSH, LH and E2. So, and that is how we would be addressing it. Okay, so now moving on, then I think we can address this question because we have some time, I suppose. How to, one of them have asked step-by-step guide for management of PCOS in young girls unmarried. So basically, you're looking at adolescent and early 20s, young girls who are unmarried and for management of PCOS. So this is quite a distinct group. So when we talk about adolescent PCOS, do you see many young adolescents, Smitha, visiting your clinic with issues with PCOS?
Absolutely. And the number keeps growing, I would say. Especially with lifestyle, current lifestyles and sedentary behavior, there are a lot of people. So the first and foremost, I think the treatment line is the same, whether they are young or old. The first and foremost starts with trying to identify their ideal body weight and trying to get to that ideal body weight with the diet and lifestyle measures. Metformin can be considered, especially in girls who are more than 18 to 18 years of age. We can consider metformin to sensitize their body to insulin. Depending on which factor of PCOS, I think the treatment would, besides diet and lifestyle, the treatment and metformin, the other treatments offered will depend on which symptom is particularly troubling for that person, whether it's anovulation, whether it's hirsutism or acne. And we decide the treatment accordingly, whether that needs to be combined OC pills or something like for hirsutism, like the drugs we discussed, spironolactone, etc. It's usually good practice to give spironolactone, which is a teratogenic drug, along with a combined oral contraceptive pill, even in young girls, to avoid any kind of problems with that. And then depending, like I said, on which aspect of the PCOS that is troublesome for them, you decide the treatment.
So here I think we haven't covered this, Dr. Smitha, this role of inositol in PCOS. Do you use inositol?
So once again, I think once again the jury is divided. Endocrinologists don't use it as much as gynecologists and the fertility experts do. But there are studies to say that inositol does help in this cohort of people. I don't know how much, but I think there's more evidence for metformin than inositol.
That's right. Yeah. So inositol, I personally, in my own practice, I don't use because
I haven't seen your patient.
There is no large body of evidence to state that inositols are helpful, so we don't. Do you use it in your patients, diabetic patients? Otherwise, no, right? You don't use inositol.
I don't personally start them on that.
Because we don't have strong evidence. So as you rightly said, metformin is the other agent which we use. Yeah, okay. Great, thank you. So I think we have come to the end of the session. Have we, Priyanka? Do we have more time to discuss anything?
Yes, ma'am, we have 4 minutes remaining. So if there's any
4 minutes, okay. Any more questions? I mean, yesterday you sent a few questions. If at all, we can address that. Ones which you have given now, yes, we have read out all these questions. Maybe to just say, I know we are today focusing on fertility aspect, but right from the adolescent age, when we see young women, young girls with PCOS, it's important to reiterate to them the importance of lifestyle issues, which can, which is the main reason these women, this PCOS gets precipitated in these women, and to maintain a healthy lifestyle all through their life. It is easily said than done, but we can reiterate even at this point that provided the health is maintained, they would not face issues during their reproductive life with fertility, and later on in their middle age, metabolic issues which these women face. Metabolic issues, of course, can happen even in adolescents. And how often do you see, young girls who have metabolic problems like glucose metabolism abnormalities or lipid abnormalities, Dr. Smitha? Is it common? Because I don't have any idea in this age group what would be.
They are presenting much younger, Dr. Vyjayanthi, especially with glucose abnormalities. I have patients as young as 15-year-old, 14-year-olds actually turning out to be type 2 diabetes rather than type 1 diabetes. So it is becoming an increasing problem. Whether all of them are not have PCOS it doesn't necessarily coincide, but a lot of them with PCOS will end up with metabolic problems, as we know from our practice through the years, if we don't catch them early and treat them early.
Yeah. So do you see lipid abnormalities as well in these young girls, and what would you do?
Certainly they can have because it's the insulin resistance which is driving the pathophysiology here. So certainly they can have, a lot of them have problems with triglycerides and the unhealthy lifestyle. Unless the LDL cholesterol or bad cholesterol doesn't tend to be very high in them, it's mostly the triglycerides, unless they have something called familial hypercholesteremia or genetic causes of lipid abnormalities.
So mostly with diet, we are trying to correct these abnormalities, I suppose.
Correct. You counsel them for a calorie deficit or low fat, low carbohydrate diet, and they do very well.
Okay. So same thing if we extrapolate into the reproductive age group, where these women who come to us who are overweight, who also have metabolic abnormalities, GTT we have discussed what we would do, put them on metformin, beautifully explained by you. But even if you have lipid abnormalities, hypertension, of course, if we diagnose, then we have to address that. Lipid abnormalities, again, in these women in the reproductive age group, if you pick up prior to their starting fertility treatment, is it diet which is, or do you add anything else also?
So the problem with picking up lipid abnormalities is there are no proven anti-cholesterol drugs or statins or any other drugs which can be used safely during pregnancy. They're all category X drugs which are known to be teratogenic. So even if we do pick up something before pregnancy, we would have to counsel them to stop immediately during pregnancy, or if they're going for fertility treatments, they're going for pregnancy, so we cannot continue those drugs. So all we are left with is dietary modifications. But again, like I said, there are some genetic reasons for very high cholesterol, so they need to be counseled differently when they are planning for pregnancy.
Yes, but most of them can be corrected if it is. But do you see these abnormalities in the morbidly obese and not someone in the range what we most likely see, say just about 30 to 35? Is it more often in the morbidly obese?
Like I said, it tends to be mostly triglycerides, which tend to be high in these people, and that doesn't necessarily translate to their cardiovascular risk, which is the main thing why you're trying to give them drugs. You want to prevent their cardiovascular risk, especially during the pregnancy period. So if it's just triglycerides and we know that their diet and physical activity is contributing to that, we don't necessarily need to start them on drugs.
Great. Thank you. One last question. I have PCOS since childhood, and I have taken several medications and continued Crimson 35. And recently I went for a checkup, and doctor suggested me to stop Crimson and take Divery 10 milligram. If miss periods in 2 months, I'm continuing that. So that seems fine. And does it have a solution, or I have to take medicines? Also, I have pimples. Shall I take medicine like Acute Red 30? How long to use Diane? Okay. How long to use Diane? So this is, Crimson 35, as the query is, Divery is quite okay. And once in 2 to 3 months is perfectly fine when you're going to go on progesterone. So that sounds right to me. But the other thing is how long to use Diane 35? Do you have when you start it for your patients, how long are you going to be using it, Dr. Smitha?
I think usual consensus would say minimum of 6 months, I would say, but maximum I don't tend to use more than one year, but might be.
Yeah, because of the issues with the liver issues, right? When we take Diane for a long time.
Correct. And recently I saw another girl also, young girl, 18 years. She's been using of her own accord. They have been using Diane for the last 4 years, and now her bad cholesterol is around 200. So she may have other issues also which caused it, but I think, I don't know, some kind of timeline should be there when we need to stop these drugs.
But these days, are we straight away just wanting to use just a contraceptive pill rather than using the Diane? That's also quite okay when they can use it for a long period, right?
That would be common practice anyway. So yeah.
And one last question I'll take, and I think we'll finish it. PCOS with hyperprolactinemia, should it be treated? If yes, level of prolactin. So what I would, prolactin levels, marginally elevated prolactin levels, we do see, at least in 15% of women who present with PCOS. Marginally elevated prolactin levels, we are not going to do anything major. We are not going to address, start specific treatment. But if the prolactin levels are higher, then of course we have to do additional tests and then manage it. So that's how I would approach it. And I think now we have come to the end of all the questions, and we have, it's past 7 too. I think we have come to the end of the session. And I would like to take this opportunity again to thank both my brilliant panelists, Dr. Smitha and Dr. Sharadha, for for their valuable inputs and making this discussion very lively and interesting. Thank you both. Thank you both. And for all the audience too.
Yes. Ma'am, it was indeed a very enlightening session, and we have addressed some crucial and pertinent questions related to PCOS and infertility. All the information that has been shared today by the panel is going to be very beneficial to our audience. On behalf of PCOS Society India, I sincerely express my gratitude to Dr. Vyjayanthi ma'am. You have put a lot of efforts in coordinating and conducting today's webinar. You have beautifully moderated today's session. Also, many thanks to our panelists, Dr. Sharadha ma'am and Dr. Smitha ma'am, for taking your valuable time out and joining us today for addressing the questions related to PCOS and fertility. Also, thanks to our backend team, web stream. Also, thanks to our audience for joining in. We hope we have covered all the questions you might be having. If you still have any questions, you can call us or WhatsApp us on 915-2919-221. Or you can write us on manager.vijayata.pcos@gmail.com. I also request everyone to follow us on Insta handle, the PCOS Society of India. We will keep you informed about our upcoming webinars. So with this, we conclude today's webinar. Happy weekend, Happy New Year to everyone. Good night. Yeah. Thank you all.
Thank you. Thanks.
Thank you.